Good morning. First of all, I would like to thank the organizing committee for inviting me to be a speaker today. Next topic will be the future trend in rectal cancer treatment. I'm the medical oncologist who can operate on my patient. It doesn't work. Anyway. And this is my disclosure. I'm going to talk about the rectal defining, open versus laparoscopic surgery, total neoadjuvant treatment, complete response after the concurrent chemoradiotherapy, what to do, future cancer staging system, cancer drug approval, sinus, and lastly, will be the biomarker. And this will be finished within 15 minutes. Surprising. For the oncologic endpoint, the rectum is defined as that 15 centimeter from the anal verge. Open versus laparoscopic surgery. In 2016, there's a meta-analysis compare between laparoscopic and open surgery for the rectal cancer. It's a 3-year follow-up. That include a data that have published before the end of June 2015. And it include 8 randomized control trial with 3,145 patients included. And the conclusion is the oncologic outcomes are comparable in terms of 3-year disease-free survival and overall survival. After that, there's 2 identical studies. One was conducted in US and Canada. It's compared between laparoscopic assist versus open surgery for the early rectal cancer, that is stage 2 and 3 rectal cancer. The first one in the United States and Canada is a cause of Z6051. The second one with the identical study design, a la carte study, conducted in Australia and New Zealand. And a conclusion from these 2 studies the same. In stage 2 and 3, rectal cancer laparoscopic surgery is inferior to open surgery in terms of pathologic outcomes. ASCO 2017, there's a long-term report, a Korean study, compare between laparoscopic and open of the mixed and raw rectal cancer. And the conclusion is, laparoscopic surgery does not compromise the long-term survival outcome in rectal cancer. In summary, for the open and laparoscopic one, for survival outcome, it's no different. But for the pathologic outcome, the open seems to be better than the laparoscopic. Total neoadjuvant treatment. It is well accepted that outcome of the treatment of rectal cancer depends on 2 factors. The first thing is the neoadjuvant treatment. And the second thing is the quality of the surgery. But for the adjuvant treatment of the surgery is still in doubt. The EORTC 229-2021 doesn't support the idea of adjuvant treatment. That's the idea of putting everything of the treatment before surgery. That's what we call a total neoadjuvant treatment. ASCO 2017, there's a report from United States, a total neoadjuvant chemotherapy to facilitate delivery and tolerance of the systemic chemotherapy and response to the locally advanced rectal cancer. And you can see that for the complete response, include clinical and pathological response. It is 21% in the concurrent chemoradiotherapy and the adjuvant treatment. And it is 36% for the total neoadjuvant treatment. It is a superior compliance in the total neoadjuvant treatment group. That's why the National Comprehensive Cancer Network version 3, 2017, they put one of the treatment options for the locally advanced rectal cancer like this. Locally advanced rectal cancer, induction chemotherapy, followed by the concurrent chemoradiotherapy, and then surgery, then surveillance. That's the idea of the total neoadjuvant treatment. Adjuvant treatment after surgery of the rectum is it or not. It's depend on the total. It's depend on the neoadjuvant and the type and quality of the surgery. Concurrent complete response after the concurrent chemoradiotherapy. What to do? In Gastrointestinal Cancer Symposium 2017 in the United States, there was a report of the international database about watch and wait policy of the rectal cancer. It is 35 institutes from 11 countries involved. 802 patients involved. In this, 679 cases is a critical complete response. And this is the result. A 3-year local recurrence is 28%. 96% is intraluminal growth. 4% is regional lymph node. 3-year distant metastasis-free survival is 92%. 3-year survival in sustained response is 92%. 3-year survival in locally growth group is 86%. And this kind of information is one that patients should know and have a chance to take part in decision making. Future cancer staging system. The US cancer staging system will be delivered in January 2018. We get used or familiar with the TNM prognostic staging, but in the near future, it should be included biomarkers in the staging. That will be listed in the 8th edition of the AJCC cancer staging that will be effective on the 1st of January next year. Cancer drug approval. The US FDA latest approval of the cancer drug is approved cancer drug on the genetic defect, not a tumor type. That means that with this approval, the existence of the biomarkers in essence defines the disease rather than the organ-defining diseases. A good example of this is the pembrolizumab. It is approved in a tumor that have the microsatellite instability high or a deficient mismatch repair gene. That is in malignant melanoma, non-small cell lung cancer, colorectal cancer, and urothelial cancer. Sinus. All of you know that the left side is the better prognosis than the right side in terms of overall survival and progression-free survival. And this is the 5 studies confirm of this. In ASCO 2016, Vinuk report overall survival in the KRAS wild type. Right side have the overall survival of 19.4 months. Left side 34.2. It is almost 14 months different. For KRAS mutant, 23.1 for the right side and 30.3 for the left side. For progression-free survival, is the 8.9 for the right side, 11.5 for the left side. But a sinus of tumor is less prognosis in the early stage of cancer. In summarize, for the sinus of the advanced colorectal cancer, it is a strongly prognostic marker. It has some role in the predictive. For biomarker, the most relevant predictive marker, that's for the anti-GFR, that is the last analysis that's used for stage 4 only. And the second most relevant predictive marker is for immune checkpoint inhibitor is the microsatellite instability, mainly on the malignant melanoma, non-small cell lung cancer, urothelial cancer, and some in colorectal cancer. You can see that the higher the burden of the mutation, the better the response. In conclusion, a true 10 and fusion in rectal cancer treatment. For oncologic outcome endpoint, rectum is defined as 15 centimeters from inner wall. All painful such as laparoscopic surgery, survival outcome is no different. But pathologic outcome often seem to be better than laparoscopic one. The total neoadjuvant treatment is one of the treatment options in locally advanced rectal cancer with a high complete response rate and better compliance. Complete response is after concurrent chemotherapy, what to do. Let the patient know this kind of data set and have a chance in decision making what to do with them. Future cancer staging system will include a prognostic biomarkers. New cancer drug approval will depend on the genetic defects rather than the organ defining the disease. Left side is better than right side in terms of overall survival and progression-free survival. We are toward the biomarker-guided treatment, both medically and surgically. Thank you for your attention.